Second white coat. Subscribe and like. Let's learn medicine together.
Okay, so picture this. A patient goes in for a pretty routine surgery, a simple lymph node biopsy. But a few weeks later, they show up with this completely new, totally baffling problem. So let's dive into this medical mystery together and piece together the clues one by one.
Our story kicks off with these really simple, everyday complaints. The patient says he's having trouble combing his hair and he can't put dishes away on high shelves. Now, on the surface, those sound like minor things, right? But for him, they're a huge deal, a brand new disability. And for us, this is our first major clue, and it's pointing to a very, very specific type of weakness. All right, let's break down the timeline here. So 8 weeks back, he's dealing with some swollen lymph nodes in his neck, plus a fever and fatigue. Then 2 weeks ago, he has surgery to get those nodes taken out for a biopsy. And now, today, he walks in with these totally new problems with his left arm and shoulder. The critical piece of the puzzle, these symptoms only started after the operation. That timeline, it points us directly to one place and one place only, the site of the surgery. So let's put on our detective hats and investigate the anatomy of our crime scene, the posterior triangle of the neck. Now check this out. This image is basically our crime scene map. You can see the cervical lymph nodes, those little green things, which were exactly what the surgeon was after. But look closer. See that little yellow line snaking right through them? That, right there, is the accessory nerve, or cranial nerve 11. And this just perfectly shows how incredibly vulnerable it is. It's running right near the surface, smack dab in the middle of where that surgery happened. This part of the neck is a pretty crowded neighborhood. You've got lymph nodes, veins, big muscles, the whole shebang. But tucked in amongst all of that is our prime suspect, the spinal accessory nerve. And to figure out why it's at the heart of this whole mystery, we first have to understand, what does it actually do? So if we're going to solve this, we've got to follow the trail. We have to figure out what the accessory nerve's job is. Because I promise you, understanding its function is the absolute key to making sense of our patient's very specific symptoms. Okay, so the accessory nerve is what we call a pure motor nerve. Now, this is a huge clue. What it means is that its only job, its entire job, is to send go signals from the brain to muscles to make them move. It has absolutely zero sensory function. It doesn't do touch, it doesn't do pain, just muscle movement. Go ahead and file that little detail away. It's going to be super important in just a minute. So which muscles is it telling what to do? Well, cranial nerve 11 has two main gigs. First, it powers the sternocleidomastoid muscle. That's the one that helps you turn your head side to side. And second, and this is the crucial one for our case, it powers the trapezius muscle. That's that big, kite-shaped muscle on your back that's essential for moving and stabilizing your shoulder. Okay, you with me? We've got the location, we've got the nerve, and now we know its job. So, here comes the aha moment. Let's start connecting the patient's symptoms directly to one of those muscles. Remember, our patient has trouble with overhead stuff. But why specifically overhead? Well, it's because lifting your arm out to the side, an action called abduction, happens in 3 very distinct stages. The first little bit, just up to 15 degrees, that's the supraspinatus muscle. Then, from 15 up to about 90 degrees, your deltoid takes over. But to get your arm above 90 degrees, you absolutely need the trapezius muscle to grab your shoulder blade and rotate it upwards. If the trapezius can't do its job, that last step just doesn't happen. You can almost think of it like a complex pulley system. Without a working trapezius muscle, that whole system just fails. The first part of the lift works fine, but that last, critical rotation of the shoulder blade is impossible. And this explains perfectly why he can't comb his hair or put that dish on the top shelf. All right, so that totally explains the weakness with overhead movements. But you might be thinking, what about his other symptoms? I mean, the physical exam clearly showed a shoulder droop. And hey, if a nerve was damaged, why isn't he complaining about any numbness or tingling? And this, right here, is where the final pieces of the puzzle just click into place. The shoulder droop, well, a huge part of the trapezius muscle's job is to hold the shoulder blade up. It elevates it. So without that support, gravity just takes over, and the whole shoulder sags down and out. And the lack of sensory loss? Well, remember that critical clue we filed away? The accessory nerve is a pure motor nerve. Injuring it paralyzes the muscle, but it can't cause numbness because it doesn't carry any sensory signals to begin with. It all fits perfectly. So the evidence is pretty overwhelming at this point. But, a good detective always rules out any other possibilities before closing the case.
So let's just make absolutely sure no other nerve injury could possibly explain this very specific set of symptoms. This table lays out our other suspects really nicely. Could it have been the axillary nerve? Nope, because that would cause weakness in that middle range of motion, not just overhead. Okay, well, what about the long thoracic nerve? An injury there causes something called a winged scapula, where the shoulder blade literally sticks out from the back, which is way different from the shoulder droop our guy has. As you can see, the only thing that fits all the evidence is an injury to cranial nerve 11, knocking out the trapezius.
And so there we have it. The verdict is in. The patient is suffering from trapezius paralysis, and it was caused by an accidental injury to his spinal accessory nerve during that lymph node biopsy. Case closed. So, the huge takeaway here, the thing to really lock in, is this classic telltale pattern. Anytime you have a patient with a history of surgery in the back of the neck, combined with a noticeable shoulder droop, that very specific difficulty lifting their arm overhead, and a totally normal sensory exam, your mind should immediately jump to an accessory nerve injury. You know, this whole case just leaves you with a really fascinating thought. It's such a powerful reminder of the incredibly delicate systems at work inside our own bodies. And it just makes you wonder, doesn't it? How often does a seemingly simple procedure end up revealing so much about the intricate, vulnerable wiring that lies just beneath our skin?